according to the current guidelines, the standard treatment of patients with stage 1 and 2 Hodgkin lymphoma is a combined treatment. That means chemotherapy plus involved field, involved site radiotherapy. Over the last 20 years, several approaches have been done to try to see if it's possible to avoid radiotherapy or to escalate the chemotherapy regimens in case of unsatisfactory response to the first two courses. Based on these two approaches, we designed the H10 study that was a randomized phase 3 clinical trial comparing PET-adapted regimen therapies or a standard treatment with combined chemo plus radiotherapy. But the news in that trial were that radiotherapy was planned with the involved nodal approach. That means very limited area to be irradiated, only in case of positivity at the beginning of the treatment. And for those patients that following early PET were still positive, the program was designed to offer escalated BCOP for 2 courses. So, most importantly, for those patients that had a good response to initial therapy and became PET negative, the approach was continue with chemotherapy alone. For those patients that were PET positive, modify treatment strategy, adding BCOP escalated for 2 courses to the initial 2 courses of ABVD. The main results of this study are that PET positive is a strong predictor of outcome. Patients with PET2 positivity have a higher risk of failure over time compared to patients PET negative. The addition of BCOP to the standard treatment in case of PET positivity translate in a better progression-free survival. Although after 10 years of follow-up, this difference is less evident compared to the analysis we performed 5 years ago. In the group of patients with PET negativity and treated with chemotherapy alone or chemotherapy plus involved nodal radiotherapy, the combined regimen was associated with a better progression-free survival. In all subgroups we studied, the overall survival was excellent in both the standard and experimental arm. So in conclusion, what I can suggest as interpretation of our results, that combined chemoradiotherapy with involved nodal radiotherapy is a safe approach and is not associated with an excess of risk of second malignancies. And the same is for the group of patients that are PET positive after 2 courses of ABVD, escalating to BCOP is a good choice because 2 courses of BCOP are not associated with an increased risk of second malignancies over time. So the implications of this study are that both the approaches, use PET for avoiding radiotherapy or intensifying patients' treatment for patients PET positive is associated with an excellent outcome. So the news is you have to discuss of the patients. There are 2 opportunities. The same chance of overall survival. If you use also involved nodal radiotherapy, you have a lower risk of relapse. If you use
BCOP, in case of PET positivity, you improve the chance to remain disease-free for a longer period of time. However, no differences in terms of survival emerged, so the patients can be informed and make the decision if they prefer to be treated less with a higher risk of curable relapse or to be cured in a little bit more intense way, reducing the risk of late relapse.